I'm Peter Eckman. I'm the head of the Advanced Heart Failure team at the Minneapolis Heart Institute, and was very grateful to be invited to join the presentations today by Dr. Berlakis and Saraja. In the interest of full disclosure, I'm a fish out of water here, being a heart failure cardiologist in a meeting with a lot of interventional cardiologists. I can spell stent, but I've never put one in. And as I was telling these guys earlier, I knew when I was a fellow I wasn't going to be an interventionalist when I would be excited about a normal coronary angiogram, because then I could go on and do a right heart cath. So that being said, I'm really glad to be here today to help continue the discussion about cardiogenic shock, which is obviously something that's an area of substantial overlap between our teams. So I will start, and then we're really grateful to have some real leaders with us on the panel this morning. So here we go. And I want to thank Philips, Teleflex, and Terumo, W.L. Gore, Assist, Sahi, Pfizer, and Cook. How do I escape here? There we go. Relationships I've had are with both Abbott and Medtronic as a consultant, and as I'll highlight on one of my subsequent slides, all honoraria are donated to our research foundation. I've been asked to provide a quick overview of cardiogenic shock today, and I will say that giving a talk on a topic like this in 8 minutes is kind of a challenge. I think most people know the way this is typically defined in terms of end-organ perfusion from low cardiac output, typically also citing a low cardiac index and or high pulmonary capillary wedge or end diastolic pressure, hypotension and or need for supportive measures. About 5 to 10% of acute MI cases are complicated by shock. This has not changed appreciably over time. And depending on the references you look at, most have suggested the in-hospital mortality is in the 50-ish% range. There are some that have noted that it was perhaps higher in the past and has improved somewhat, which we always like to see. In terms of diagnostic tools, they range from the mundane vitals exam, urine output, to the laboratory tests, pH, lactate, chemistry panels. Echocardiography can certainly give clues. Ejection fraction alone certainly does not define this, but one thing people will sometimes use is an LVOT velocity time integral. And obviously, I'm a big fan of the Swan-Ganz or pulmonary artery catheter, which is a critical part of this. And I think one of the things that I was gratified to see in some of the work from Dr. O'Neill and his team in the National Cardiogenic Shock Initiative was suggesting that patients that had hemodynamic monitoring may have had some benefit. As a heart failure cardiologist, we often get criticized of why do you use so many PA catheters, and people cite the ESCAPE trial, which has some important pitfalls to it, but I was, of course, gratified as someone who's a PA catheter enthusiast to see growing support for the role of hemodynamics in decision-making in these patients. When we treat patients with shock, revascularization's been certainly very well established, and that would be the proverbial bringing coals to Newcastle for me to presume to tell interventionalists how to revascularize people. But I think one of the debates that's really coming to the fore is whether or not revascularization should be done before or after mechanical circulatory support, and the US PELA registry is suggesting a benefit, and I'll make a couple more comments about this later. In terms of medical therapy, as the sort of proponent of medical therapy here today, I'm here to say that what we have is a little limited, and the data on it is pretty embarrassing. We use volume management, optimizing preload, diuretics, or volume, controlling blood pressure and heart rate to try to minimize oxygen consumption. Obviously, some of the pitfalls of this include if you use an inotrope, those can actually increase oxygen consumption. They can be arrhythmogenic and can have, pressors can have an adverse effect on microcirculation, all of which can decrease tissue perfusion and increase acidosis. Mechanical circulatory support obviously then becomes of some interest, and as someone who's one of my primary interests is in durable ventricular assist device support, I'm certainly a fan of this, and it's something that we use a lot in our interface with these patients. A balloon pump has been around for quite a while, but the studies on it have been disappointing, and it's actually considered a Class 3 indication in European guidelines. We also have devices like ECMO, Impella, Tandem Heart, and pitfalls from these devices can include the risk of bleeding, limb complications, and access issues. These are enormous cannulas. One of my friends who's an interventional cardiologist tells me that every time he puts someone on ECMO, he feels like he's taking a spear and stabbing them with a giant spear. And so this is certainly a dangerous thing that we do to people, but there are also folks that have a very high risk of mortality without aggressive treatment. Based on currently available data, there's no clear winner in terms of the right device or the right approach. In terms of medical therapy, I did a bit of a literature search here to see what I could find supporting this, and thought, well, I'll go to the Cochrane Review there, let's see what they have to say. They found 13 studies with over 2,000 participants, but 1,700 of these were from a levosimendan study. And overall found that there was low quality evidence suggesting a short-term mortality benefit from levosimendan compared to dobutamine. Everything else was inconclusive, including comparing levosimendan to placebo. So one could argue that we have essentially no data on the use of medical therapy in cardiogenic shock patients following acute MI beyond revascularization. So there's certainly no convincing data to support this, and this is something that I would say is on us collectively to look for opportunities to improve the evidence base surrounding this. And of course, one of the challenges is that nobody's going to sponsor a gigantic randomized trial of furosemide in these patients because they're complicated patients. It's an expensive trial. It's a drug that's been around forever. So there's some practical reasons why this has been a challenge. Acute mechanical circulatory support, there's two large strategies in the face of the fact that balloon pump is, the data has been declining or is at least not as aggressively supportive. The first is the tandem and Impella camp, and the other is more the ECMO camp, and it's a little bit like politics. On some level, you sometimes see some disputes and strong feelings on either side of the debate, but I think we really all can get along, and there's a lot of room for us to work together. One of the studies that I thought was interesting looked at the outcomes. It was a meta-analysis of 4 trials comparing mechanical support, Impella and tandem heart with the balloon pump. And this was a short-term follow-up from this pool of studies. All-cause mortality was virtually equivalent, but there clearly was an improvement in the hemodynamic level of support that you saw from mechanical devices. Higher MAP, the index and wedge were not different, but lactate was better, and there was a higher risk of bleeding. And here's the graph showing the dispersion of the different studies. And so I think what I take away from this is that there certainly is some evidence suggesting that the mechanical circulatory support options are more powerful in terms of their hemodynamic benefit. There have been studies looking to try to help us understand risk stratification. I think one that I thought was interesting and is potentially very useful in that it's my friend and colleague, Dr. Nick Burke, who I don't know if he's still in here, if he had to run, told me that I needed to use short sentences because I was talking to interventionalists, and of course that's not true, but I can very much appreciate the idea of concise risk scores, and this is one that I think has some potential for us to make some upstream risk stratification predictions. Also wanted to note in terms of what else has been published and available in randomized studies, the Empress study, I suspect most of you are familiar with, was almost 50 cardiogenic shock patients after acute MI randomized to percutaneous support versus a balloon pump. High percentage of these patients with arrests, very high lactate. I think that arguably is one of the potential criticisms of the study is, were these patients too sick and should they have more of them gone on to ECMO? Again, found a roughly a 50% 30-day all-cause mortality. As I mentioned earlier, one of the debates that I think is flaring up and in a good way, and this is from a review that was just published. In fact, I got the date wrong. It's from 2018 because it was just published here earlier this month. Dr. Kapoor was one of the co-authors in this review by Nir Uriel, who's a heart failure cardiologist at the University of Chicago, highlighting the potential benefits of unloading first to minimize or improve oxygen demand, and hopefully that may reduce infarct size. And so there is a trial that's ongoing, as I understand it, has completed enrollment to compare whether or not unloading prior to revascularization offers an advantage in terms of infarct size. So I think, as I see it, there's a number of unmet research needs in this field. It's a little puzzling on some level that the hemodynamic improvements of mechanical support haven't led to a clear and convincing mortality benefit, although there's some hints of signals of that. And I think that the work that the National Cardiogenic Shock Initiative has been doing is clearly increasing people's interest in this and is suggesting the potential for improvements. Large randomized trials in medical management, as I said, just haven't been done, and there's very little out there. A lot of the work that's been done is being driven by the acute coronary syndrome population, and as someone who takes care of the full spectrum of heart failure patients, there's a lot of people that have cardiogenic shock that didn't start out in the cath lab, and so I think that's another area that I hope that we as heart failure cardiologists will be assertive in participating in that process. Risk stratification gives us some potential for deciding on the triage of what device when and how aggressive we should be and when. I think there's also merit. These are very expensive therapies in making sure that we are judicious in terms of when we deploy them, but that's very difficult to say. It's been argued if you have a patient that comes in that has let's say they have a 75% chance of dying if you, even if you intervene and are effective, but they have a 100% chance dying if you do nothing. So that 25% increase in survival is a number needed to treat 4 patients. So I think it's easy to make the argument that the sickest patients are the ones that may merit the most aggressive approach. And it's also been suggested, and I can't take credit for this, although I have to admit I don't remember where I first heard or read it, whether we should be testing a strategy as opposed to a specific device of unloading, for example, or lowering filling pressures, reducing oxygen consumption, and letting centers decide based on their local expertise of what's their best approach of how to achieve that strategy, much like has been taken in the septic shock population.